Hello everyone. So yesterday night, I was putting a central line, and I felt that there is a requirement to teach other than the actual process of procedure of central line. What other things need to be taken care of while putting a central line? It is basically for nursing staffs in ICU and also for the new joining resident doctors for ICU. So when we are going to put central line, the first and most important thing is the informed consent. The informed consent means that you have informed the patient or the patient relative that these are the indication, these are the risk, and these are the complications that may occur, and what are the other option if you don't put the central line, and why it is important. So mainly informed consent, in that even the 1% chance of some negative thing is going to happen, that we need to tell, and those things should be informed, and then consent, a written consent should be taken. The same procedure has to be explained everything to the patients if the patient is awake and can understand the things, so that for them the procedure doesn't become a panic situation what is going on. The next step is that everything has to be done in aseptic condition. So before going and scrubbing your hand and putting gown, a doctor should make it sure that the nursing staff has attached the monitor, the ECG leads, SpO2 probe, and BP monitor, and he should also check with ultrasound the best place where to put the line, whether right side or left side or subclavian or femoral, which is the best route. Although femoral is nowadays avoided because of high risk of infection, subclavian routes is less preferred now, because internal jugular ultrasound can be done easily, and subclavian ultrasound is still is not that much done very nicely, and if the patient is in ICU there will be coagulopathy, so in that case subclavian routes are avoided. So mostly internal jugular route is preferred. So the doctor should see which is the best vein, central vein, to be punctured before going and scrubbing and putting a gown. Before that only, once he or she can see that. Then the third thing, after scrubbing and after wearing a gown proper, you have to check everything is there in place, what size of central line you want, central venous catheter you want, and all the if the local is required, if the patient is not sedated, then local is there. You have proper whatever you want, the flush and everything is there. Then you start doing that. Before doing that, the probe cover, probe cover should always be applied. There should be if you don't have probe cover, then use gloves. Gloves can be also used with aseptic precautions, and extra sheet you can use to cover that wire part of the probe. And head to toe sterilization, head to toe covering with a sterile sheet is important. Before putting this head to toe cover, you have to clean the wrap and clean the area which you are going to puncture. Always make it sure you are starting from the center and going peripherally. It should not be randomly. Start from the center and go to the periphery. That is the way we have to do. And before all this, position is very important. If you are planning to put on right side, make the patient on the right edge of the bed, and the top of the near the near the head end. And so this is very important. And the position of the the patient, the operator, the doctor should be at a comfortable position. If possible, put on Tenderberg position. So it also as it engorges the vein, so it will be more easily accessible. At the same time, it will also prevent air embolism. But there can be certain time, certain conditions, certain patient in which it's maybe not possible to do a Tenderberg position. In such patient, if possible, just while before pricking the line, you can put the patient on the Tenderberg position. Or in some cases, we have put line in the proper position because the patient was in such a respiratory distress on an IV. We have to put on that position, but it rarely happens, but it can happen. We have to be ready for all those things. So as time goes, you do more and more procedure, you become better and better with that. So once you have prepared, you should put local. We have to give local anesthesia if the patient is not sedated, because we don't want to give any pain to the patient. As much as we can avoid, we have to as a doctor, if we can't avoid, like if we know that if we will give some local, there won't be any pain. Why not to give local? So we have to give local. And before inserting local, aspirate and check that you are not in any vessels, because we have to put it in a subcutaneous sprain. Okay, so these are the things. Now once the time out should be clear, like it should be like, okay, this is the patient name, this is the procedure we are going to do, and this is the site where. So time out should be done by the nursing staffs and the doctors too. So after that, once you are putting central line, nursing staff should always be, because monitor will be in the back and the doctor is doing the procedure. So now the nursing staff role is very important. While putting the guide wire, there may be chances of some arrhythmia, VT, VF. Yesterday it happened while I was putting the line, and because there was an alarm, so I immediately, okay, there is like, okay, this guide wire has gone inside. It is touching the endocardium, so I have just withdrawn it. But the nursing staff should also know. Suppose that alarm, the alarm setting has been changed, and or for some reason or the alarm, it is a machine only. It may not like sometimes give you alarm or read the right arrhythmia. So it may not give the alarm. So the nursing staff should be able to say, ma'am, something is going wrong, please see. So must teach your nursing staff that what to see while you are putting a line. So if there is bradycardia or some VT, VF or arrhythmia, immediately withdraw the line and the place where that arrhythmia stopped, that is the right place. Now make it sure that this guide wire has stepped out. Speak it loud, and the nursing staff and the people around should also see that guide wire is out. Okay, because this sometimes it can happen that there can be guide wire embolism. You may have left the guide wire inside, maybe like we are human beings only, so that's why the confirmation is very important. The multiple people should recheck the same thing. So this is the thing. And while when we are withdrawing the blood, that time also as a doctor and also the assisting staff should see the color, should see the flow of the blood aspirated. Sometimes even in hypotension patient or the severely hypotensive patient, in which line we often put line, there can be chances that the arterial blood may not be having that much flow, or the patient is severely dehydrated, the arterial flow may not be that much pulsating, and in that condition venous, the arterial blood may be misunderstood as a venous blood. So that's why ultrasound is very important. It should be done under ultrasound. It should not be once you have seen the, okay, here is the vein and you just remove you keep the probe aside and then you put continuously. One hand the probe should be there, and with another hand you have to just while looking on the ultrasound machine, you have to put the line. That's why line, the side you are putting the line and the ultrasound all should be in the same axis, same line. That is good. Otherwise you are putting there and you will see there it's not right. That's why it is said that all the things should be in the same line. Ultrasound monitor should be also on the same line. So this we have to do. So another if there is a hypercarbia, CO2, patient has retained CO2, in that condition also sometimes you will get the blood could be dark because of the CO2 non-oxygenated blood. So in that case also you may get darker color blood and you may think that it is a venous. So that is why ultrasound guided you have to do. Don't even after putting the guide wire, recheck that okay, I am in the vein only, I am not in the anywhere else. Other way to confirm whether if you are thinking that you have a suspicion that it is a arterial, you have punctured a arterial line, you can just attach that with the IV set. If it is coming like back, so it is arterial line. If it is easily the fluid is going, it is venous. So even more than that you can do even ABG if required. So these are the things. If you have punctured arterial line, so in that case you have to remove and compress it for 10 minutes and take it out and check if there is no bleeding, it's okay, and check for any hematoma. If suppose you have cannulated, you have put guide wire, you have dilated the artery, carotid artery. So in that case, the book says that it's a medical emergency. Of course it is a medical emergency and vascular surgeon should be called, and they will only take it out. We should not do that. So I think and this after doing the procedure, make it sure you do one chest x-ray, and diligent care of the central line is must. Proper dressing and you have to take proper care of the central line. Thank you.